My dear students, we are discussing Cor Pulmonale, and we have discussed the classification in the last classes. That is, it is classified as acute variety, subacute variety, and chronic Cor Pulmonale. In that acute variety comes the acute pulmonary embolism. In the subacute variety, asphyxial and malignant conditions are there. Then the third classification is chronic Cor Pulmonale. Then today we can discuss what is chronic Cor Pulmonale. Here there is hypertrophy of right ventricle resulting from diseases affecting the function and structure of the lung, except when these alterations are the result of diseases that primarily affect the left side of the heart or congenital heart disease. So basically, you know what is Cor Pulmonale, that is heart disease secondary to pulmonary disease. So it is a hypertrophy of the right ventricle resulting from diseases affecting the function and structure of the lung, except when these alterations are the result of diseases that primarily affect the heart. അതായത് ഹാർട്ടിനെ പ്രൈമറി ആയിട്ട് അല്ലെങ്കിൽ ഫസ്റ്റ് ഹാൻഡ് അഫക്ട് ചെയ്യുന്ന ഡിസീസ്, ലെഫ്റ്റ് സൈഡ് ഓഫ് ഹാർട്ടിനെ അഫക്ട് ചെയ്യുന്ന ഡിസീസ് അല്ലെങ്കിൽ കൺജസ്റ്റീവ് ഹാർട്ട് ഡിസീസ് ഒക്കെ അല്ലാതെ when it occurs as a result of this hypertrophy of right ventricle occurs as a result of diseases affecting the function and structure of the lung, then we can group it or say it as chronic Cor Pulmonale. Then we can move on to the causes of chronic Cor Pulmonale. What are the causes of chronic Cor Pulmonale? First of all, disorder of airways and lung parenchyma. Disorders of airways and lung parenchyma. What are the common conditions which can lead to lung conditions that can lead to chronic Cor Pulmonale? First of all, the most important cause is COPD itself. COPD, that comes chronic bronchitis, emphysema, then obstructive diseases like bronchial asthma, then infiltrative diseases, fibrotic lung diseases, inflammatory lung diseases, example tuberculosis, bronchiectasis, pneumoconiosis, then radiation fibrosis, sarcoidosis, cryptogenic fibrosing alveolitis, extrinsic allergic alveolitis, scleroderma. All this can lead to chronic Cor Pulmonale. Chronic Cor Pulmonale is one of the complications of all these diseases. These are the important disease of airways or lung parenchyma leading to chronic Cor Pulmonale. Then there are certain disorders of thoracic age also leading to Cor Pulmonale, that is kyphoscoliosis, then thoracoplasty, etc. All this can lead to chronic Cor Pulmonale. Then neuromuscular diseases are there, for example, myopathy, dystrophic diseases, then myasthenia gravis, neuropathies, then spinal cord transection, polio, etc. All this can lead to Cor Pulmonale. Then gross obesity is otherwise called Pickwickian syndrome. Pickwickian, Pickwickian syndrome. Then high altitude is another, or moving to high altitude is another reason for chronic Cor Pulmonale. Then sleep apnea syndrome, again another reason for chronic Cor Pulmonale. So these are the reasons or causes of chronic Cor Pulmonale. Again, I will repeat, that is disorders involving airways and lung parenchyma, disorders of thoracic cage, then neuromuscular disorders, then obesity, high altitude, and sleep apnea syndromes. These are the important causes. Then we can move on to the Clinical features. First of all, we can divide it into two types: compensated stage and decompensated stage. We can divide clinical features into compensated stage and decompensated stage. So let's move on to the features of compensated stage. Here, there is evidence of basic lung or pulmonary vascular or thoracic cage disease. Basic evidence of lung disease, disease of pulmonary vasculature, or thoracic cage, disease of thoracic cage. Then features of pulmonary hypertension like angina, syncope, fatigue, then peripheral cyanosis, then presence of giant A wave. In the AVP tracing, you can see giant A waves in JVP. Then right ventricular heave. Right ventricular heave is another finding you get in compensated stage, right ventricular heave. Then closely split second sound with loud P2. Or the pulmonary factor of the second sound is accentuated. Loud second heart sound with loud P2. Then pulmonary systolic or diastolic murmur is also another feature. So these are the features of compensated stage. Then let's move on to the features we get in decompensated stage. Here we can see two broad types of categories of patient that we have discussed that in the complication of chronic bronchitis or advanced chronic bronchitis or CBES, chronic bronchitis emphysema syndrome. That is blue blotters and pink puffers. That is the decompensated stage. In blue blotters, there is features of or signs of right heart failure, like hepatic tenderness, edema of ankles, then right ventricular gallop rhythm. And because of this raised cardiac output, the hands are usually warm and blue, and arterial blood gas reveal severe hypoxemia also. So these are the features of blue blotters. Blue means the blueness is due to cyanosis. Blotter means blotted appearance. It is due to edema. So two features are present in blue blotters, that is cyanosis and edema. Then another percentage is pink puffers. Pink puffers, here there will be breathlessness. There is hyperventilation on least effort. This is mainly seen in advanced emphysema conditions. In pink puffers, edema and hypercapnia occur in a later stage. Usually there won't be, or in the initial phase there won't be edema and hypercapnia. Breathlessness or hyperventilation is the main feature in pink puffers. And then blood gas levels are almost normal in case of pink puffers. So that is the decompensated stage. So we can divide clinical features of chronic cor pulmonale into compensated stage and decompensated stage. Then regarding the investigations in chronic cor pulmonale, as usual, ECG is taken. In that we can see right ventricular hypertrophy. There can be features of partial or complete right bundle branch block. Then polycythemia. Blood polycythemia is another feature. It is related to chronic hypoxemia. When there is chronic hypoxemia, it can lead to polycythemia. Then X-ray shows enlargement of features of enlargement of pulmonary artery with diminished peripheral vascular shadow. Then ventilatory function, we can do ventilatory function test or pulmonary function test, and definitely there will be features of airflow obstruction. We can do a forced expiratory volume in the first second layered by forced vital capacity. That is the ratio FEV1 by FVC. It has a obstructive pattern, and that ratio is reduced in chronic bronchitis or chronic emphysematous patients. And in restrictive diseases, this FEV1 by FVC ratio may be normal. In case of obstructive disease, it is FEV1, FVC, forced vital capacity, FEV1, FVC ratio is diminished, and that ratio is decreased. It is normal, almost normal in restrictive disease. And this restrictive defect is, or this FEV1, FVC normal ratio is in interstitial lung diseases. So these are the common investigations. Then about the management of chronic Cor Pulmonale. First of all, management of pulmonary disease. How can you manage pulmonary part? Here we have to give specific therapy for diseases like tuberculosis, which is due to tuberculosis or occur as a complication of tuberculosis. Then treatment of bronchiectasis. Then if there is infection, antibiotic therapy. Then avoidance of bronchial irritants. Main irritant, that is smoking. If the patient is a smoker, definitely he has to quit smoking. Then improvement of ventilation. How can you improve ventilation? That is, they will give bronchodilators. Then reduction in the stickiness of sputum or reducing the viscosity. This is by liquefaction or lowering the surface tension by inhalation of trypsin or detergent-like material. Then oxygen therapy. Oxygen therapy is also useful. It relieves anoxia and central cyanosis. Oxygen therapy. So these are the management of lung component or lung diseases. Then management of right heart failure. There is management of right heart failure. There is right heart failure. They will give digitalis with much care. Then diuretic, if there is edema, they will give diuretics. Then mechanical assistance is also given. Sometimes respirators may be given to increase alveolar ventilation. Emergency, or some patients may need tracheostomy. So these are the management techniques employed in chronic Cor Pulmonale. So management of lung component, management of right heart failure, and mechanical assistance. Okay, that's about the management of chronic Cor Pulmonale. So we have discussed the acute presentation, subacute presentation, and chronic Cor Pulmonale in detail. Thank you. So students and dear friends, just go through the source textbooks and prepare brief notes for examination and all. Thank you so much.